Uh, my names are Mohammed Said. I'm a healthcare consultant, and I've been in this healthcare space for over a decade now, slightly over a decade. So when it comes to SHA, before I explain the issues of SHA, I think we need to look at the genesis of SHA. SHA is a component in the UHC, which we call the healthcare financing. This is where we finance our healthcare, the Social Health Authority. The journey of UHC started way back in the 1990s. When it started in the 1990s, there was a clamor to implement SHA by countries across the world. It was a WHO, initially it was a WHO document that recommended countries to adopt a universal health coverage, but many countries did not adapt, including Kenya. Then came around 2003, when the then Minister for Health was Charity Ngilu. We had a bill in Parliament that was passed, which we call the Gill Bill. That Gill Bill was passed by Parliament to advance the legal framework for implementing universal health coverage in Kenya. The Gill Bill was not assented to by the then President, Mwai Kibaki. The reason why it was not assented to by the President was because there was some level of lobbying from the private insurers at the time, and the billionaires who are running that private insurance industry. They prevailed upon the President to shoot it down and take it back to Parliament. And that's where the journey died. The journey towards UHC died there. Then, under the new administration, the current administration, which is of President William Samoei Ruto, we had the President decided that he will implement UHC. It was part of his manifesto. Then in 2023, October, we passed the Social Health Insurance Act. The Social Health Insurance Act was now supposed to advance our UHC and implement it. Under the Social Health Insurance Act, we had three components. One was Primary Healthcare Fund. We had those funds, which we call one is the Primary Healthcare Fund. The second one is Emergency, Chronic, and Critical Illness Fund. The third one is the Social Health Insurance Fund. The Primary Healthcare Fund was a fund that was supposed to finance our primary level of care, which majority of our Kenyans actually seek services from level 1 to level 3. And majority of our Kenyan citizens, they seek services from primary level facilities, and that is where 85% of our health needs can be addressed. And the government, under the Social Health Insurance Act, the government was the one who was supposed to pay for all those services under the primary health care. The other one was also Emergency, Chronic, and Critical Illness Fund, which was supposed to cater for the emergencies, the medical emergencies. When you get an emergency, probably maybe it is an RTA, you are evacuated by an ambulance. That ambulance is supposed to be paid for by the government. So you are supposed to be evacuated to a health facility for those emergency care. That is, the government pays for those services under now the SHA model. So for primary health care and for also emergency care, the government pays up for all these services. The only fund that is now a contributory fund is what we call the Social Health Insurance Fund, the SHIF. And this is where a lot of noise is there, under the SHIF, because Kenyans are not understanding what is going on. on this arrangement of SHA. For you to access services under SHA, for you to access those free services under the primary health care and also under the emergency care fund, you are supposed to just register. You don't pay anything. You just register. Once you register, the government is the one that is supposed to pay for that services now. If it is delivery, if it is maternity and delivery and stuff, and also basic things like probably an outpatient visit to level 2 facility where you go and see a clinician, where you are clerked there by the clinician, and you are supposed to go to probably a small lab there to do those basic tests. Then you go to the pharmacy, you get the medication. It's fully paid for by the government. Now, where the noise is coming from is Kenyans are used to what we call the free buys. You just decide to go to a health facility when you don't have any registration. You have not registered for anything. You just decide to go to a health facility. You want to access services, but you are told, oh, you are not registered. You need to register at least so that your details are inputted into the system to process you to access services. You don't want to do that. You go to a facility, a hospital, you have not registered. Then after now, when you're getting discharged, is when you now demand to be discharged for free, without any registration, without anything. That's where the challenge is with the provider. The provider now, when you are not registered for the fund, any of them, PHC, primary healthcare fund, the emergency fund, and for the shift, you are not even registered, and you go to a hospital and you are discharged. You are clerked there, you get services and you are discharged. The provider will obviously ask for cash because you have not registered. That's where the matter is.
Yeah. And just as you said, Mohammed, do you think the main issue that is with the shift issue, a lot of people are not understanding because maybe they were saying with NHIF, people knew that they're only paying for NHIF. It was only one word, NHIF. But now with this a new model, there's the SHA, as you've explained, there's the shift, and then there's also the one that saying there's the primary coverage with almost 85% of Kenyans are contained in that category. And then there's the one you are saying that so long as you just registered with your details, you can be able to access these services. But then again, people will say, why am I then being, if I have a salary, why am I being deducted money that is going towards this health coverage? And also, the money that people are being deducted from the salaries of the models that you said, where do this money go? Are they spread equally, or do they go into one account, which is then covers the whole health cover when I go to a hospital as a Kenyan citizen?
Yes, that's a very good question. The thing is, for that deductions that you're talking about for those salaried employed Kenyans, it's usually deducted at a rate of 2.75% of the gross salary. And of course, it is true that the rate could be higher when you look at the payments that they used to do to the NHIF, which was the payment auto that you're used to deducting from your pay that Kenyans were used to before. Under the NHIF, you could still be employed. You are deducted the NHIF, but it was not a guarantee that you get services. There's no guarantee that you get services because the NHIF deductions were just statutory deductions. You could still go to a health facility and you are denied services. Yet you have been deducted already that amount under NHIF. But under SHA, when you pay 2.75% of your gross pay, the government already has your data that you have contributed. So when you go to any facility, any public facility, or any private facility that is already onboarded into SHA, you will get automatic services. That's the difference.
Yeah.
Now, under also SHA, you are getting very many services which were never there also in the NHIF package. Under the NHIF package, you could still contribute, but you could not get any services. Why? Because your employer did not have an NHIF super cover agreement with NHIF. So, which we call the comprehensive cover, the NHIF comprehensive cover. So you could contribute, but the employer has to still go to NHIF and sign a different contract with them for comprehensive cover, and that's where you will again, the employer also has to contribute to NHIF to advance the cover. So majority of Kenyans who contribute, whether you are employed or you are not employed under the old NHIF, you used to contribute, but the services were different.
Yeah.
Because within the NHIF, we had very many special groups, which we call like managed schemes. So we had 96 managed schemes under NHIF for these special groups of people, not the whole population of Kenya that SHA is doing now. You had the teachers. You had some county governments. I think around 6-7 of them, they had a comprehensive cover with NHIF. So they were treated as a special group within the fund. You had also employees of the national government who are enjoying a comprehensive cover also under NHIF. We had National Council of People with Disabilities. Those people who had disabilities within Kenya, they were also being paid for by the National Treasury, and they were treated as a special categories of people. Then the elderly. Then there was also another component we had, which we call the Linda Mama, which initially started as a different fund under the Treasury, but was transitioned to NHIF. So under NHIF, we have special categories of people who are enjoying services, but majority of other Kenyans were contributing, but they were being told the NHIF is only able to pay for your bed, you get sick.
Yeah.
So the rest of the bills you used to cover out of pocket, which is not the case under SHA. And that is, I think, the gist of the matter.
Yeah.
As per my understanding.
And then there's also that Kenyan also who says that, yes, already, as of now, Mohammed, you've explained to us the difference between SHA, SHIF, and all the models that are there. You've also explained to us the money that's being deducted from a salary, the 2.75%, where it goes and how it does the funding for me as a Kenyan citizen. But there's a person who will say, from a case point, yes, I have registered, I've been paying from my salary has been deducted, everything is okay at par. But when I go to a level 2 hospital, I was assisted. When I went to level 5 hospital, I wasn't assisted. In such an issue, this particular Kenyan, why are they not getting services at the level 5, and yet they're getting services at level 2? And then some of them might say, but with NHIF, I could get services at level 2 and still at level 5, and all of them were covered by NHIF. But now with SHA, there's some difference. Why is there a difference when it comes to this specific case?
I think it's lack of information. Yeah, that's where the problem is. Majority of Kenyans visit hospitals to seek outpatient services. That is 85% of our problems are. Our health needs is at the outpatient level, which we call the primary health care. So when you are a Kenyan, under the SHA model, you enjoy primary health care from level 1 to level 4. So if it is a level 1, it's a community health unit. Level 2, it's like a dispensary. We have those dispensaries in the village. Then level 3 is a health center. Then level 4, which is a fully fledged hospital.
Yeah.
So you could go to a level 2 facility, you could go to a level 3 facility, you could go to a level 4 facility to get those services. That is where the primary care is. But if you decide to go to Kenyatta, which is a level 6 facility, but you refuse not to go to Mbagathi or Mama Lucy, that's where the problem is. Why do you want to go to Kenyatta? Kenyatta is supposed to be a hospital where you go there for super specialty services that cannot be addressed at this lower level of care. So instead of going to Kenyatta, you could go to Mama Lucy when you are in Eastlands. You could go to Mbagathi Hospital. Nobody has denied you services there. So Kenyans now do not understand these issues.
Is it the specific case that was there because there's a patient who went to, I think, a level 6 hospital, but they were told your case is too small to be handled at this facility. Kindly visit a level 4 or a level 3 facility. And it created a lot of noise because people were saying it's like the hospitals want now this person to be really, really sick so that they can now, SHA can now cover their level 6 needs. Do you think that that's fair? It's just the thing as it is at the model, and that's how it should work in the policy paper and also in the implementing stage?
I think that did not even come with SHA. It was even there before. If your issues, there's what we call a referral system within the healthcare industry.
Yeah.
So when you go to probably level 3 and you go and see a clinician, and you are a walk-in patient, an ambulatory patient, you are a walk-in patient. You came and see the clinician, he clocked you, he prescribed you some medication, and you go home. It's a very basic thing. So, but maybe you had a headache, or like maybe you felt a bit under the weather, or maybe you had some medication maybe for diabetes. Maybe if you are sick, you had medications also for hypertension that you feel now you need to refill. So that's where you are supposed to go. Those facilities that are there from level 2 to level 4. You could get all your medications there. You could get all, where 90% of our problems can be addressed at that level. The reason why we have such a policy is because we don't want to overcrowd our level 6 facilities. The challenge with Kenyatta is grappling with is because everyone wants to go there. Yet your issues can be addressed at the lower level. We have a grading system within the healthcare. So when you're in Nairobi, you have you have a facility that is near you, a private facility. You have mission facilities that are run by missionaries. You have public facilities also that are near you, level 4, level 3, level 2. Why do you opt to go to Kenyatta? You should be referred there by the doctor there at these other facilities. When he sees your problem is quite advanced, they can't address it, then they give you a referral. Yes. Yes.
And there's also the issue of some hospitals were saying that they have been removed from the list of the hospitals that are going to be funded by SHA because they're saying that they had conducted these procedures, and some people are saying that some small health facilities are doing even more operations even than KNH. In that situation, can this hospital now say that yes, this issue is an issue that could have been handled maybe by a level 6 facility, but at our level 3 facility we have the necessary equipment and the necessary expertise in doctors to be able to cure this, maybe to have this surgery, to have this operation, and that's why we did it. So we are demanding our rights to be paid from SHA itself. And that issue of some hospitals being denied their rightful claim, which so even an association like RUPA, the Rural Private Hospital Association, try and pull out from the SHA system. Do you think that's an issue that needs to be addressed, or is an issue that was politicized?
I think there's an issue of fraud. Fraud actually is a global problem. Under every insurer globally, the percentage is usually 15% of all the claims could be fraudulent. Under the new SHA model, when we were trying to pass those legislations, and also the subsequent regulations that were gazetted, we had what we called when you want to be onboarded onto SHA to provide services under SHA, the process was actually made seamless. It used to be very bureaucratic under NHIF, the old NHIF. For you to be onboarded to provide services under NHIF, it used to take up to 4 to 6 months for a hospital to be onboarded to provide services under NHIF. But under SHA, everything was simplified. Once you are a hospital, you're already providing services to the public, and you are registered, you could immediately be onboarded on SHA. You could onboard yourself even online. You just sign a contract, then you you're onboarded, and the following day you start providing services. And now this is where a loophole was created, because we had and when a hospital is registered, it's not registered by SHA. It is registered by Kenya Medical Practitioners and Dentist Council. It is the council that is supposed to register facilities. That's where the problem is. So when that process of registration is not done procedurally, and there's no diligence that is conducted by the inspectors of KMPDC, where they could go and verify the facility if it is existing, confirm this facility is providing services, then they do the inspection, the physical inspection, they write a report, then from there it is issued with a registration certificate. But that was not happening. It was not happening. So these fake facilities were created. A loophole was created to fake facilities were registered. These fake facilities now, they onboarded themselves on SHA. SHA does not have the capacity to verify if the facility is fake. It is not the role of SHA. So these fake facilities were created, they onboarded on SHA, they started claiming now, generating fake claims. Asking for people's IDs, identity numbers, they input them into the system, then they start generating claims on SHA. So that was the initial stage of SHA, from probably around December to around April, before the CS Duale came into office. So where they were, now the scandal became big. Now those facilities that actually had were implicated in those fraudulent practices, majority of them were actually suspended. Some were actually again re-inspected and closed. And for those fake ones, the file actually is with the DCI. They're the ones who are supposed to prosecute now, working in with the Director of Public Prosecutions. And I'm told as of last week, which is on Thursday, around 10 individuals were arrested. Yeah.
And what measures are there in place currently to make sure that, yes, there's as you said, there's a 15% chance of fraud happening in every insurance system, but now when it comes to SHA, because it's health is a primary need for each and every citizen in Kenya, what are the current measures that are there to make sure that these hospitals that are claiming to be paid each and every time, each and every month, are genuine? Because in every other sector, we usually have an independent body, from the police to the doctors. Even in parliament, you have the ESCC, which is an independent body to counter-check. For sure, how are they able to do this? Or is it just from the ministry itself, and maybe the organizations, associations such as KMPDU are the ones that are going to see that this hospital are making fraudulent claims?
So what happens is, these facilities are actually registered by KMPDC.
Yeah.
Then they are onboarded on SHA for services, provide services under the Social Health Authority. When there are fraudulent issues, and maybe SHA decides that some claims that were being generated by some facilities are fraudulent, they have their own due diligence they conduct. SHA also has compliance officers on the ground who are able to actually do verification. They see, and report those suspicious activities that are happening in the country regarding healthcare facilities. Now, when the SHA confirms that some facilities are engaging in generating fake claims, they usually suspend them, or they withhold those claims not to be processed. They have within the system there are very many modules where you are able to address issues very easily. So if it is a payment and a claim that was generated from a facility, and there's a high suspicion that it is fraudulent, immediately it is flagged. Yeah, that's where SHA is able to get information. Then they're supposed to they'll flag, and then it's not processed. That bill is not processed. So facilities now have a right for recourse on that. They are able to now liaise with SHA to understand where the problem is. If there's an issue of maybe a documentation that is missing, that's creating this problem of maybe that is suspicion that it is fraudulent, they're supposed to address. And actually there's a narrative. When you see facilities complaining that their bills and their claims are not being approved, there's a narrative usually there. You're told maybe submit more documents. if there's any, if you are maybe trying to bill for SHA for a service that you are not allowed even to bill, then you cannot generate, you cannot be paid for that.
Yeah.
The other issue now, is if you engage in fraud, it's a criminal offense. If it is confirmed that you've engaged in fraud, it's a criminal thing. So the government has the right procedures. We have our courts, we have our independent bodies like the DPP, we have the Department of Criminal Investigation. Yes, they're the ones who are supposed to now do their work.
Yeah.
That's why the CS now sent his those files to the DCI.
Yeah.
Yes.
And there's that part of, as a Kenyan citizen, when I see that at least the ministry is trying to curb these hospitals that are doing fraudulent cases, as a citizen, I'm happy because the government is trying also to have due diligence in the system. But there's also that person who's watching and they've understood already that how they can get into SHA, how they can get services with SHA. But there's that person who doesn't now understand. For example, if I have cancer, for example, if I have diabetes, at what level now should I visit which level of, as you said, this level 2, level 3, level 4, all the way to level 6? Kindly explain to us what the outpatient services, that's the primary care, and the inpatient services. Does SHA also cover inpatient? And at what level should I, as a Kenyan, go for inpatient services through SHA? And what type of diseases should I go in what level of hospital through SHA?
Thank you. Now, when you get sick and you go to a hospital, the first thing you do is you go to the outpatient department. That's where you meet the clinician, you are clerked, and if the clinician feels and he does some lab works, basic lab works, and he feels you are too ill, then you are admitted. So when you are an outpatient and you are clerked and maybe they feel like you could get better, they'll probably be given some medication at the pharmacy there and you go home. But if the doctor now has clerked you and he sees, you meet the criteria to be admitted, you'll be admitted.
Yeah.
So once you get admitted now, that's where now what we call the shift will kick in. But at the outpatient level, it is the primary health care. The shift will kick in.
Yeah.
No, when the shift kicks in now and you are admitted as an inpatient, now that's where now the insurer, which is the social health insurance fund, that specific fund now is supposed to be the one that's supposed to cater for you at that level. So from there, for that fund now, which is the shift, you have to be registered and be paid up also. There's a premium that you're supposed to pay for shift, for you to enjoy services under shift. For that premium, it is usually there's what we call the proxy means testing. That means testing is when you are registering, after you register, they will give you a certain premium depending on the level of income you have. And it is just a very easy thing.
Yeah.
So if it is 300 shillings you're supposed to pay per month, in a year, it is equivalent to 3,600 shillings. But under NHIF, they used to pay almost 3 to 4 months ahead. They used to aggregate the figures to 2 to 3 months, 4 months, then you are supposed to pay. But under SHA, you pay lipa mudogo mudogo. You pay daily if you want.
Yeah.
You can pay, if it is 300 shillings a month, you can pay 10 shillings daily. You can decide to pay 60 shillings weekly or 70 shillings weekly. It is just an easy process. But now, when you have not registered, you have not paid the premiums, and you are admitted as an inpatient, and you are treated. If you don't have any cover, under SHA, you are not covered, you are not registered, then you are supposed to pay cash. That's where the problem is. Kenyans are not doing all these things. Now they just end up in a hospital and they want to be discharged. It doesn't work like that. Even for other private insurers, they have their own processes.
Yeah.
There's pre-authorization process. When you are supposed to be admitted, they have to be notified, the insurer has to be notified, paperwork has to be done. So the paperwork that is supposed to be done has to be done. There's no other way about it. That's it.
Yeah. And also there's someone who might also ask, there's that transition that happened, yes, from NHIF now to this new model, the SHA model. For people to say whether SHA is working or not, what are some of the things that they're going to look at to say that SHA is working? For example, are they going to look at the number of people that have enrolled into this SHA model? Are they going to look at the number of people who have paid up into this SHA model? Or are they going to look at the number of people who have benefited already in this SHA model, maybe since its inception? And also, when you're answering that, you can, for you, from where you sit as Mohammed, you're a healthcare consultant, somebody who is very vast, has vast knowledge in this system. What are some of the loopholes that you've seen currently that maybe the Ministry of Health or maybe the people who are concerned can improve so that this model can even be strong enough and deliver more than it has delivered currently up to this stage?
I can only say one thing about whether SHA is working or not. SHA, if you are registered, you enjoy primary health care, you enjoy emergency care if you are registered. That's it. That means SHA will work for you.
Yeah.
If you are not registered, then SHA is not working for you. Don't care about whether others are registered or not. It's a personal initiative. Make sure you get it, you register. Once you register, you can enjoy the services. For SHIF, make sure you pay the premium. If your premium is updated, you will enjoy services. SHA will work for you very, very, very well. Nobody is going to bother you. But if you don't register, then SHA is not going to work for you because you are not even registered. SHIF also is not going to work for you because you have not paid the premium. That's where the problem is. And let me try to advance this. Under SHIF, you are supposed to register, then at least pay a premium, the one that is allocated to you. If you don't pay that premium, you will have problems. And the government right now, I think as of last week, they said 26 million Kenyans have registered for SHA.
Yeah.
Out of these 26 million, not all of them are contributing to SHIF, which is now the contributory fund. And the NHIF, they used to contribute, but the services, sometimes you see cancer patients, they used to have issues with NHIF, because NHIF used to say like, oh, if you are supposed to probably pay that premium, at least a year is when you are able to access services for cancer, maybe those chemotherapy. But under SHA, if you immediately pay, maybe you are already a cancer patient and you already been diagnosed and you are already enjoying services, you are getting the chemotherapy on time. Under SHIF, you can pay daily. So and the cover is up to 550,000. You pay daily and the cover is up to 550K. Daily, if probably the premium is 300, you pay maybe like attention is daily. You can even pay attention is daily. Lipa mdogo mdogo.
Yeah.
But NHIF never used to offer that services. NHIF used to request you to pay at least a year of premium before you enjoy the services.
Yeah.
Coming to now the issue of me recommending on how we can improve this thing. I think, in my opinion, SHA is the best thing that has happened in this country. Very honestly, it's the best thing that has happened in this country. Because under NHIF, the old model, we used to even have those many fundraisers on WhatsApp. They're no longer there right now. Where are they? They're not there. Why? Because if you are someone already who is, you have long-term illness, you have some chronic illness like maybe cancer, or you are maybe on dialysis, you have kidney problems, you are on dialysis. Right now, everything is covered under SHA. Everything is covered under SHA. But under NHIF, they never used to pay for everything.
Yeah.
Now, I can only encourage Kenyans to register, to be able to register, to also pay for SHIF, which is a very important, and that's for them to access that services under SHIF. That is one of the recommendations I can do to any Kenyan.
Yeah.
There's no way about it. The other recommendation I can make is the government also to make this fund sustainable, to make the SHA sustainable going forward. I think just 2 weeks ago, I think the government decided to pay for the indigents, the vulnerable population. There are around 2 million of them. The government has decided to pay for, which is a very commendable thing. The government is meeting now the premium for these indigents. It's even for elderly people who are not productive. For our other Kenyans, also our vulnerable groups, like also the mothers at the maternity level, we had what we called the Linda Mama. Under the Linda Mama, we saw there was a gap with NHIF in 2013. That's when Linda Mama came into existence. But it struggled with a lot of lack of funding.
Yeah.
Sometimes the donors are chipping in, paying. Later, the government, the treasury was supposed to pay for it, and the money was not being remitted to that for that. And it was transitioned in 2016 to NHIF. So we had a situation where Linda Mama was actually operating in a gray zone, because it never had nobody was registering for it. You just enjoy the services in a public facility. Later, they also brought in the private facilities. But the problem was, nobody could verify if the claims that they were generating was legitimate. Yes, there was no way they could verify.
Yeah.
Because there was no NHIF card that was being issued to these mothers. So we also had an issue of providers like health facilities also trying to bill for both. They were billing SHA, they were billing NHIF, again they were also billing Linda Mama. So under Linda Mama, they had for normal delivery, they were reimbursing 2,500 in a public facility. In a private facility, they were reimbursing 3,500 for the same. For cesarean section, they were reimbursing 5,000 for public facilities, and they were reimbursing 17,000 for private facilities. And for mothers who had also the NHIF super cover, when they go to a public facility or a private facility, and these providers were taking advantage of the fund. They bill NHIF for the cover, the super cover. Then they used to also bill separately also for Linda Mama, meaning they were still engaging in fraudulent practices. That's why even as per the Auditor General's report, it was not a sustainable thing to continue with.
Yeah.
That's why we have SHA. SHA is now our child. The only thing we can do to SHA is to improve it. You see? Yeah. The only thing we can do to SHA is to improve it.
Yeah.
Yes, I understand that there are some issues. It has some issues, maybe in very small areas. We can only improve it, but we can't have something better than SHA.
Yeah.
It is the best thing.
Sasa, Mohamed, tumeshukuru sana.
Thank you so much.
Thank you for creating time to come and have this